I'm with the Adelaide meeting.
Oh, good.
Yeah, it's good.
The rooms, you never get the rooms right, and good, we didn't realise that they were renovating. So we were really hoping we were going to be. I'm sorry if that inconvenienced you.
Good quality vital speakers are excellent. Yeah.
We had a special,
Pretty good guy for Jensen.
yeah, well, we fell into the sea. Thank you.
Yeah, it's good earlier. Is that going to be a permanent change?
Yeah, but we needed to,
Get away from you again.
away from all the other meetings, just killings.
Yeah.
Particularly the European one.
Yeah.
Because this is bigger and bigger.
Yeah.
And it meant that not only did we have trouble getting speakers to come out and say, well, this is Europe, but a lot of our own members were going, yes, and I thought, well, that's just stupid. So we moved back to all this.
Yeah.
That was good.
Yeah.
And we're going to have it over the weekend, so that, it'll only take up 2 days.
Yeah. Well, you're Americans are like Saturday, Sunday, Monday, Tuesday.
Sorry?
DPW stuff, Saturday, Sunday, Monday, Tuesday.
Yeah, and it used to go forever, didn't it?
Yes.
Starting Saturday and all day.
You have 6 days of entertainment.
That's right.
We told you this is literally for next year, this is Thanksgiving tomorrow, they won't.
Oh, right.
It's scripted.
Yeah. Well, we've been into trouble. I didn't realise what it was presented 3 years ago. This year felt smack me over the ground. There was a lot of happy letters to the society. What can you do except apologise? It won't have to be. There's always something. No matter what you do,
Yeah.
I'd like to be reminded when unless somebody tells me
It's supposed to be Americans that start putting cities. So that's always cool. It's in somewhere like Prague or Vienna or Paris. It's always in
English is now a more applicable language for everyone, whereas previously we would have some speakers that only spoke it.
Good morning. I think we'll make a start for the session. So today's program looks nice and full. Flavour's a little bit different to yesterday, where there was a lot of liver content. So a lot of the stream today is you can follow a whole endoscopy stream through most of the day. So the first session we're going to talk about pancreaticobillary interventions, and we've got 4 great speakers lined up. And to set the tone, we have Ian Norton from Sydney, and Ian is the current head of Department of Gastroenterology and Hepatology at the Wayne Hospital in Sydney. He has many peer-reviewed articles, and he's a great endoscopist, and he'll teach us many things. So Ian will let you kick off with when he asks you.
Outlet, and it may well be that, God bless them, but I've never seen a study of not doing as many now as they used to, but in previously has done 5,000 or 6,000, is going to have a cumulative experience that they can draw upon. And there's data certainly, we've got high volume, and because we've got high volume, we keep our skill level up and even get better once we've finished training. And that becomes a self-fulfilling thing, that you get better and better as your volume goes up. I would mention, I don't know what high volume means. I used to think a couple of hundred a year was pretty good. But when I was a fellow working with Todd Barron, he'd previously worked at UAB where he was doing about 1,500 a year by himself. And when he went to Mayo, his numbers crashed down to 500. And he was lamenting to me one day that he was only doing 500 a year and he could feel his skills slipping away from him. So I don't know what volume is necessary. But then the issue is the guy who has, and I think mainly I'm talking about surgeons in rural areas here who have adequate training. One over the age of 50 probably trained with just midazolam and fentanyl. Needle knife access got a bad rap back in the 90s, I think, because Peter Cotton, who kind of says things from back in the good old days, it was said that it was about a 15 to 20% pancreatitis rate, and that was part of the reason why it got a bad name. But the problem was that no one really reached for a needle knife until they'd been struggling for 10 or 15 or 20 minutes and the papilla was a mess. So many of those patients were going to get pancreatitis anyway. So was it indeed the needle knife, or was it the repeated attempts that were causing the problem? And there was this study done from Wellesley Hospital with Greg Haber, where they randomised people to going to a needle knife early or persisting, just keeping on poking and hoping that something would happen. They got 680 patients with a native papilla. 64 had failed cannulation after 12 minutes, so that's about a 10% failure rate. And then they randomised those patients to either needle knife or persistence. And the results of persisting or using a needle knife were the same, 75%, so they ended up with about a 97% access overall. And the complication rate in this series, and this is in the era before rectal NSAIDs, was actually lower in the needle knife compared to persistence, although this didn't reach statistical significance. And that suggests that indeed it's the repeated attacks on the papilla that cause the pancreatitis rather than anything about the needle knife per se. Nonetheless, it should be used sparingly. There's one guy in Sydney who does it within about 30 seconds of trying. If he can't get in, he goes straight to a needle knife, and I don't think that's right. And if you are going to use it, I think you should use an intelligent generator with an endocut mode so that you can't accidentally do what's called a zipper incision and do an uncontrolled cut. One of my predecessors at my hospital, behind his back, was called Zorro because that's what his needle knives all look like. And you want to avoid that. So needle knife technique, the first thing to do is just stop and have a look at the papilla and think about the anatomy of the papilla. And this is a bulging, this isn't a great example, I guess, because it's a bulging one which looks pathological either from a tumour or a stone. But nonetheless, if you just look at this, you can visualise that the bile duct is running up in this direction, somewhere in the middle of this, and the pancreatic duct is kind of coming up here and then diving inwards. Okay? So you want to kind of cut down into this sort of area. Now, when I learned how to do ERCP, or when I learned how to do needle knife, it was with Chris Gostow, and he used to do what was called a fistulotomy. So he didn't actually start here and cut up. He used to start in the middle and cut down there. And the idea of that was perhaps a somewhat naive hope that the pancreatic duct had already separated and was diving deeper by this point, and that by cutting here, maybe you were going to avoid the pancreatic duct. I don't know if that's true. It was a philosophical thing. There was no data to support it. But, you know, monkey see, monkey do. So that's the way I used to do them. I'll point out that Michael Burke thought this was a terrible thing because he thought that was leaving a little tiny sump here, which I think's garbage, but anyway. The more standard way of doing it is to start at the os with a nice controlled cut, having done a couple of practice sweeps first with the needle not perhaps all the way out, and then cutting gently up in this direction. And I do that now for two reasons. First of all, if I do a needle knife, the patient's been banged away at for 15 minutes. There's a bit of edema there. I think they are at high risk for pancreatitis, so I want to put a pancreatic stent in anyway. So the idea of trying to avoid the pancreatic orifice, I think, is gone. And there was no evidence that this fistulotomy technique was any better anyhow. So that's what I do now, but not because Michael told me to. And this is kind of what the technique is. There's a papilla, there's the needle knife. Note that it's not all the way out because you want to control the depth of the cut. And then you start at the os. They've buried it in the os here and they're just cutting gently up to make in a straight line. This is kind of aggressive. This isn't me. I don't think I would have cut it quite that much. But hopefully you see as you do this, the tissues fall open. Often you actually see the white muscle of the bile duct and you can cut down directly into it, and that's really nice when that happens. It doesn't always happen. Or you see a little blush of bile and then you gently probe with a hydrophilic wire and get up. And then do a completion sphincterotomy with a normal sphincterotome. And this is just to remind me, to mention that I think these patients should have a pancreatic stent and rectal indicids if not contraindicated. It's really important to know when to stop. If you're swearing or if you start punching inanimate objects, and I'd include registrars in this group, but early on in my career, I remember once it was very stressful and I actually whacked an x-ray machine and I thought, this is just stupid. So I haven't hit anything since, and that was about 15 years ago. But recognise when you're starting to lose the plot and you're starting to get stressed, because your chances of getting in at that point are very low. And the longer you get a diminishing return, the longer you go, the less likely you are to get in anyway. So stop. If the patient's on inotropes, they can have a PTC or something else that I'm going to talk about in a minute. If they're not on inotropes and they're not that sick, get them back in 48 hours after the edema's settled. Either you or a colleague. I don't think it matters. I'm fortunate to work with some great colleagues, and we have lists every couple of days. So typically one of them will do it, but if they're not around, I'm happy to do it. And I think, I don't have any data for this, but I think at least 50% of the time you'll get in if you do that. Now, Bronte Holt, when she was working with Rob Hawes, published a paper in GIE in 2015 where they looked at EUS interventions for patients with obstructed bile ducts with failed ERCP, and their numbers were very small. And their numbers were very small because in their institution, their non-success at ERCP was less than 2%. So they made the point, and I think it's an important one, that if you are going to use other potentially more invasive techniques like PTC or EUS-guided techniques, you shouldn't reach for those. If you've got a failure rate of 15% or so, you should look to your own techniques and try and get better at ERCP, because these other techniques should be preserved for certainly less than 5% of cases, I think. So PTC, this is what we've all leaned on in the past and I continue to do. It's fairly definitive. It's rare that they don't achieve the outcome. It has some certainty to it because they're only working on it over a short distance in a straight line. So their talkable wires, etc., are much more effective than we have with ERCP. But the problem is that they'll often put in a drain, establish drainage, muck around, and the patients often spend a few days to a week in hospital while they fiddle around with all their drains and things. And certainly that's a financial impost, not necessarily a clinical one for the patient. There's two possibilities. One is to do it as definitive treatment, so the radiologist does everything from that point onwards, puts in the stent, etc. The other is to do a rendezvous procedure. In most institutions, that's logistically difficult because you've got to either organise a time when the interventional radiologist will come up to your unit or you go down to his, or more commonly what happens in our institution is they'll put in a drain and we'll feed a wire down and do an ERCP ourselves. And that seems to work quite well most of the time. But of course, in order for this to work, you have to be able to get to the papilla. So the failed ERCP, because of altered anatomy, this doesn't work for. Potentially it could be one procedure if the radiologist is happy to do the puncture in your department and you're willing to do the ERCP while he does that, although with time constraints and logistics that's difficult to do. And if you can do it that way, you can avoid having large drains being in the patient's side and then therefore a smaller PTC puncture. The complications are said to be cholangitis in about 2%, significant hepatic artery injury with things like pseudoaneurysm formation or haemophilia in about 2%, and they very frequently have some abdominal pain due to trivial leakage of bile after the procedure. Okay, so that leads me on to, is that the next slide? It leads me on, So that leads me on to EUS guided access, and I have to be honest and say this is something that I have no personal experience of. I'll give an ad for Frank, who's giving it a talk in the video forum on something along these lines in the gallbladder, I think. Is that not true? Yeah. And this has become popularised over the last 6 or 7 years. And the idea is that you use an EUS-guided puncture to get into the biliary system, either within the liver or in the extrahepatic bile duct, and then do something. From a logistics point of view, the advantage of going into the liver from the stomach is that you don't require intact anatomy here. Okay, so that's good for people that have had whatever whipples or what have you. It's a fairly straight scope with a stable position, but the problem, of course, is that you're making a track between the stomach and the liver, and that maybe isn't something that people might want to do. The alternative is to put the EUS scope into the duodenum and puncture the bile duct when it runs behind the duodenum, and certainly this is only a very small distance to traverse and fairly easy to do. The problem is that in order to have a stable scope position, it's with a long scope with the tip in the bulb here, but if you look at it, you're actually pointing in the wrong direction. If you want to get a wire to come down through the papilla so you can do a rendezvous procedure, it's much easier to do if you're in a short scope position, kind of an ERCP position, but pulled back a little bit further. And everyone who does gastroscopy will know once you've pulled back and you're in the bulb, you're often going to slip back. So this is a fairly unstable position. It's a nicer position in terms of getting the wire to run in this direction if that's what you want to do, but it's a more technically difficult procedure from the scope standpoint. Irrespective of how you puncture it, there's basically then two things you can do. Three things you can do. One is you feed a wire down into the duodenum, irrespective of how you got into the biliary system. Then you pull that scope out, go down with the duodenoscope and do a rendezvous procedure, similar to as one would do with a PTC. One other alternative, is to get access down through the stricture, and particularly if you're in this type of puncture, you can then feed a stent down this way. And do the whole procedure from here without having to do a rendezvous procedure. And the third is to put a stent through the puncture that you've made, either from the stomach into the liver this way, or a connection between the bile duct and the duodenum. So they're the three options that one can do. And so just to reiterate that, the techniques are via hepaticogastric puncture. This is best for hilar or CBD strictures with wire placement into the duodenum and a rendezvous, or antegrade stent placement, or stent placement into the stomach, as I just discussed. Or via a duodenocolloidal puncture into the distal bile duct. This is best for bile duct strictures with a rendezvous with a retrograde stent placement, or antegrade stent placement, or stent placement to the CBD and the duodenum. And there's some data on using a thing called a hot axios stent, which is a stent which was developed for pancreatic necrosis drainage, as a way to achieve that anastomosis, if you like, between the bile duct and the duodenum. So this is a new technique, and this is the life of a new technique. Someone has an idea, and they get fame, fortune, and lots of free trips around the world, depending on whether some company's making a buck out of it. And then a few more cowboys come along, and then there's the bandwagon, and it's all wonderful, because there's all these papers coming out which are completely uncontrolled, and because of the publication bias, no one ever publishes something going wrong, particularly if it's an early in their career. They only publish the wonderful outcomes, and then you reach the summit of the summit of Mount Unrealistic Expectation. At some point, someone publishes a paper with a p-value, and it all comes crashing down. And this is the endoscopic literature is littered with these sorts of things. Well, I won't go into them, but there's just an awful lot of things. Stretta and Terex, a whole bunch of things that did this. When we look at things in a proper way, they just don't pan out to be as good as they were. And then you end up in the valley of despair. What a piece of crap. But then it actually gets better and you end up with appropriate usage. And I'm not quite sure where these EUS techniques are. I think it's an issue of, I'll come back to it, I think it's more an issue of experience and just using them appropriately and sparingly. Which means, by definition, it's going to be in the hands of a relatively few number of people, because not enough people are going to get a volume to get experience with them. So, how good is it? Poinclu in endoscopy last year published his series of 101 EUS drainages. Interestingly, most of them were transhepatic, and I would have thought most people would try to do from the duodenum into the bile duct, but 70% of his were transhepatic, transgastric. 66 of those, he put a stent between the stomach and the liver, and in only 5 of them he did a rendezvous, so passed a wire down into the duodenum and then did a more traditional ERCP. 30 of them were extrahepatic, i.e. generally via the duodenum. Overall, he had a clinical success of 92%, which isn't bad, and it didn't matter whether he went through the bile duct or the wall of the stomach. The success rate was about the same, and that seems to be borne out in other literature. The problem was he had 6 deaths, and interestingly, he had 5 deaths in the first 50 cases, so he had a 10% mortality in the first 50 cases that he did. And that's kind of an interesting thing. If I knew that I'd killed 10% of the people I was doing a new procedure in, I'm not sure if I would have had the guts to go on and do another 50, but that's what he did, and he demonstrated this learning curve, if you like. One wonders about the consent processes involved. And this is the way you do it. This is an EUS scope in the stomach. A 19-gauge needle has been used to puncture the liver on the left side of the liver. There's an injection of dye. You can see a stricture here. He's passed a wire down. There's a wire now curling up in the duodenum. You can go on and then do an ERCP and put a stent here. Alternatively, this is someone who already had a stent in the common bile duct. There's a stricture here, and it looks like maybe a stricture here as well, although subsequently he only really treated this one. I guess the first thing I wonder about is, assuming that he could get to the bottom of the bile duct here, it seems unlikely to me that treating this little segment of liver would have made a huge outcome to the patient, but nonetheless, this is what they did. They injected here, they saw this stricture, they dilated it up, and then directly from the stomach, put a stent, a metal stent, partially covered from near the hilum, back into the stomach. And when you look, you can see this is the bile duct stent. This is the transverse stent going from the left duct radical into the stomach. You can see it there on CT coming into the stomach, and there you can see a picture of the back of the stomach with the stent in it. The concern with this technique that a lot of people have, although the results are pretty good, but the concern that everyone has is that there's nothing anchoring this stent on either side. So the concern is that there could be some movement and the whole thing could come adrift, but that doesn't seem to have been a big issue. This is doing a rendezvous procedure from the duodenum. So this is the EUS image of the bile duct, the scope down in the second part of the duodenum. The first part of the duodenum, and you can see so the needle's heading in the right direction. There's a cholangiogram feeding a wire through, and then grabbing that and doing a traditional ERCP and putting a stent in. What about lumen-opposing stents? This paper was published this year looking at 57 patients where they got this new Axios stent, which is, as I said, was developed for pancreatic walled-off necrosis. And the idea is that this thing looks like a cotton reel. One end deploys in the stomach, one end deploys in the cavity, and this helps stop it from migrating, and it also helps keep apposition between the stomach wall and the cyst cavity. Well, why not do that between the bile duct and the duodenum? And that's exactly what they've done here. They've punctured the bile duct and they've placed one of these stents. And this can all be done, this is actually designed to be done by Ken Binmuller under EUS guidance. So that's what's been done here, and you can see the stent at the end in the duodenum connecting through to the bile duct. And in this paper, technical success in 56 of 57, clinical success in 55 of 57, and two duodenal perforations that required surgery. So, pooled results. There's actually a lot of this being done around the world now, and a paper by Wang published this year of 14 studies of altogether nearly 1,200 patients with a technical success rate of 95%. And again, it doesn't seem to matter whether you do it via transgastric or transduodenal, the success is about the same. Functional success of 92%. And again, this demonstration of a learning curve. Of studies published before 2013, there was 91% success. Of those studies published after 2013, 96% success. But again, you have to wonder about publication bias. People don't publish their failures. And significant adverse event rate, 23%. and overall bleeding in 4% of patients, significant bile leak in 4% of patients, and a death rate of about 1 in 200. Now, pancreatic access. I have tried to do this once and it failed, but that's all right. Obviously, PTC is not an option if someone's got an obstructed pancreatic system. And an example here would be someone, for example, who's had a Whipple and the pancreatico-jejunal anastomosis has stenosed. So from the back wall of the stomach, it's relatively easy. I won't say very. It's relatively easy to puncture the pancreatic duct, do a pancreatogram. And the easiest thing to do, I think, if you can, would be then to feed a wire down this way. And if you can do an ERCP, do a rendezvous and do whatever you need to do. Or if you can't, maybe do something from above. And that's what was done. In this case, they fed a wire down, then did an ERCP, did a sphincterotomy, and put a stent up into the pancreatic duct. So this patient had normal anatomy. What about direct stenting? This is a case of someone who'd had a Whipple procedure with an obstruction at the anastomosis. A wire was put through and then a double pigtail stent was fed so that one end of the pigtail is in the jejunum, the other end of the pigtail is in the stomach. So there's a connection being made between the pancreas and the stomach. And I guess this is a temporary solution. They then need to do something, probably maybe come back at another time, wire this and stretch up the anastomosis. Although they've done it there anyway, to stretch the anastomosis there. There's not that much data, 13 series of pancreatic punctures, 232 cases, rendezvous procedures in only a few of them because in most cases I think it was altered anatomy, transluminal A transgastric drainage in 187 and a complication rate of 18%. So significant but not bad. So in summary, when ERCP fails, I think the requirement for other approaches should be less than 5%, assuming that the patients have normal anatomy. So if you're sending a lot of people off to do these other techniques, I think they should give one pause, particularly since in the US now, people are advocating doing a quick ERCP, and if you can't get in, that's okay, just zip the patient around and do one of these EUS approaches. I think that's probably a little bit gung-ho at this point, but we may get there eventually. PTC is relatively expensive, but it's well established and it works. And EUS approaches are certainly gaining acceptance, but they're potentially time and resource saving, but there does appear to be a significant learning curve. Okay, thanks very much for your attention. Which I'll probably direct to him because he knows a lot about one during the lap chole, and then we're cut down onto the stent, so I'll let them do that. That's a bit safer if they're cutting down onto a defined structure. But otherwise, yeah, it's hard to know when you're happy to do it. Depends on the fellow too, I think, to a large extent. But I think that's certainly something for a fellowship rather than someone beginning to learn how to do ERCP.
Any idea why the needles on the needle are so long?
Yeah, I think that's a really good point. I saw Ram Shatani doing a needle knife at a meeting once, and I thought it was one of the best learning points I've ever heard was that he said, don't put the whole thing out, just put it halfway out, and then you're controlling how deep you can cut. And I think that's really, really true. I don't know why they're so long.
And the unfortunate thing is they change size as you push them down as well.
Yeah.
All right, we'll move on to...
Thanks.
Thank you, Ian. Our second speaker is Stella Johns. Stella has joined Wellington Hospital over the recent months after returning from the US. And Stella's brief is to tell us about getting out of obstruction.
Thank you. So for an endoscopist, you say gastric outlet obstruction. I say duodenal stent. But there is something to think about in this topic. So really, who should you say yes to and who should have surgery? How are we going to place the stent? How might we manage the associated biliary obstruction, which has been touched on in the last talk? What are the alternatives? And then just finally, what about benign disease? So malignant gastric outlet obstruction can be the presenting symptom or a complication of known illness, probably complicates around 20% of pancreatic cancer, particularly as patients are perhaps living a little bit longer. And gastroenterology is usually the first port of call. Now I'm in that phase of my career where I'm going from being told what to do by my boss to being told what to do by my colleagues. And I think it's just interesting to think about the decision-making process for putting a stent in. So if you're thinking about a patient who's being palliated for esophageal malignancy, whether they go to radiation or they have a stent, often that decision is a discussion in the oncology MDT. For a colonic stent, those patients are usually under the surgeons. We get asked to put them in and we might push back a bit, concerned about that perforation risk, whether the patient might have avastin. And we get clinical success sort of nearly 90%, and then 2 to 3% of patients having migration and perforation and sort of a variable rate of stent occlusion, depending on what kind of stents we use. So just looking at a couple of series, this is a prospective study of 5 countries, and Westmead was involved in the study. So high technical success, quite high clinical success. And then just looking at the patency, sort of 86% at 60 days, but the median survival of the patients is 47 days. 63% of stents patent at 180 days. This is on Kaplan-Meier survival curves, but only 10% of patients are alive at that time. So the stents are doing a good job for this set of patients. Adverse events are quite high, but that is mostly stent occlusion, some migration and a couple of perforations in this series. I think one was related to trying to perform an ERCP through the stent. This is a series published this year in GIE, retrospective study, again high clinical and technical success, so around 3 days till the patient's able to tolerate fluids again, sort of 4 to 5 days till they're able to tolerate a solid, semi-solid diet. And then in this series, again, median survival of the patient of 88 days and the stent remaining patient for longer than that. So various complications, they've divided into early and late, really again stent dysfunction with overgrowth and ingrowth being the most common thing. They had quite a high rate of jaundice in this study, and then not insignificant bleeding and perforation as a late complication. So the reason this one got into GIE was that they did analysis of some predictive factors for success. So what predicted initial clinical ineffectiveness, and this was patients with a poor performance status or with more than 3 or more sites of stenosis. What predicted recurrence of obstruction, again interestingly poor performance status, and then they found that a covered stent predicted migration with a hazard ratio of 12. And then for adverse events they found a lower rate actually with the covered stents once you excluded migration. Lack of chemotherapy predicted adverse events, and for perforation, the only predictive factor they found was deployment of 2 stents. So looking at stenting versus surgery, this is sort of nearly 10 years old now, but really making the point that obstructive symptoms were much more common after stent placement, whereas for patients who had had a gastrojejunectomy. This is probably the most well-known study. It's a randomised controlled study from the Dutch Centre. So basically a multi-centre study. They had about 77 patients who were eligible for the study, but half of them declined to participate. They wanted a stent. So small numbers in both arms. So they showed that stents were superior for short-term results. So hospital stents, would you place a 3rd stent when these patients are living, through 2 stents? Now the colonic stent literature comments or shows that the perforation rate is higher with increased axial force. So when you start telescoping your stents, you're going to have technical and clinical success. There's a high rate of late adverse events in the stent group, and then the median stent patency was 125 days, 282 for the surgical arm, and then even after additional stent placement, as per those last 2 studies, it's still favourable for surgery. So they also found a better survival in patients that had surgery, and that was really only in the ECOG 0 to 1 patients. So they recommended surgery for patients with very good performance status over stenting. So really I think if you referred someone for a duodenal stent, then people who have a life expectancy of more than 6 months, how do you know that? Patients who have a good performance status, patients who have favourable histology, so I guess I would mean people who have something other than hepatobiliary malignancy causing the problem, so for example breast cancer, those who have neuroendocrine tumours, and then perhaps people who have gastric cancer over pancreatic, and then those who are undergoing or planning for active treatment. Those patients should probably at least have a discussion about the surgical option. So enthusiasm for what you know is all very good, but you do need to do some preparation. So what information do you need? So the patient really does need to have some symptoms, not just a narrow duodenum. You don't really want them at the point where they've got intractable vomiting. You want to catch them before their nutritional status falls off and get them before they start on TPN, as Chris would say. You do need a histological diagnosis. You don't want to be stenting someone with a lymphoma. They should have had recent imaging. You want to exclude that this is actually a small bowel obstruction, very similar presentation. And then you'd like to know something about the biliary tree if they've got biliary obstruction, and you do actually need to see a set of LFTs. And then again, performance status and the sort of prognosis and treatment plans from the oncologists will feed into what you do. So we've discussed who not to stent. If they're too sick, so most of these studies actually exclude patients who are ECOG4, so patients who are bed-bound, so you don't really know the outcomes in them. This study here found that if the patient had all three of these features, so ECOG 3 or 4, high opiate use and high pain score, then their 30-day survival was less than 10%. So you really don't want to stent these patients who are sort of nearly terminal if you can avoid it. The question of extrinsic obstruction always comes up. Not very keen, having seen quite a few stents migrate. If you can get through it with a scope, you probably don't want to do it. If it's very tight, then you're probably going to be pushed into it. You won't always know about distal obstruction because obviously the contrast's not going through your proximal obstruction on the scan, but should be suspicious of this if it's not a periampulary process that's causing the problem, and it's a good reason to use fluoroscopy and inject contrast. Peritoneal carcinomatosis, it's not a contraindication, something I always be concerned about. This series showed 80% success in patients with gastric outlet obstruction and carcinomatosis, but they had poorer outcomes in patients who had ascites and a poor performance status. And then Leonidas is another sort of not a lot of evidence. So how are you going to do it? So the first thing you should do is worry about aspiration. So not all of us have anaesthetic support. If anaesthetics were involved, then they would intubate this patient from the get-go. In some places they will be used as a bridge to either ERCP or waiting for histology, which seems very expensive. So choose your equipment. So you probably want an 035 ERCP wire. You want a therapeutic gastroscope ideally, and you can use a smaller scope to go through the stricture and then backload. So place the wire under endoscopic vision if you can, or through a cannula if you can't. You want to confirm that wire position with fluoroscopy, so you really do want to be in a fluoroscopy suite for this. You must inject contrast if you didn't traverse the stricture with the scope to confirm that you are actually in the lumen, the wire hasn't perforated. And then it's nice to know that that contrast goes distally. And then you need to assess the stricture. It's a little bit more tricky than for an esophageal stricture, which is straight line. You could measure it with the scope, you can outline it with contrast and pull your cannula back. And then you need to choose a stent that will overlap by several centimetres on either side because the stent is going to foreshorten. And then deployment, so scope in the stomach, watching the top end of the stent, into X-ray to confirm when you're poking it in that it's passing easily around that corner. And then you need to choose where you want the top end. So the majority of these strictures are going to be antrum or first or second part of the duodenum, but if you can, then you would avoid covering the ampulla so you can get back there later. And then you can't just deploy this all in one go. So it's been suggested to deploy it in two halves, let the stent bed in so it doesn't go sort of running down the small bowel and disappear. And then ideally after you've deployed it, you want to see a waist. And if you're unsure, then you should be putting contrast in so you can place a second stent if you haven't overlapped the stricture. And then really you should avoid going back through the stent at that time, as you might push it down. So post-procedure, the stent's going to take up to 48 hours to dilate, and they're going to start on their modified diet. This just illustrates the sort of difference between immediately post-placement and then stent expansion at 48 hours, so don't start them on solid food too soon. And then what about the bile duct? Obviously covered partly in the previous talk. So 60% of patients with gastric outlet obstruction will develop biliary obstruction at some point. So, it's the same processes. So 50% of them already have a stent in place at the time of this. If you can, you would swap it for a metal stent. 20% will develop this at the same time, and so you would stent if you can. Otherwise, you might want to consider either PTC or perhaps an EUS approach at the same time. And then 30% of them will develop it following stenting. So ERCP is described as feasible. People always talk about doing ERCP through a duodenal stent. I have to say I never saw it even once during my training, so I assume people are not very enthusiastic about it, and these patients often get done by the radiologists. Then you could ask the question, does a duodenal stent interfere with biliary drainage? After all, it's going over the bile duct, or if you've got a stent there, it's going to be overlapping that stent. So this patient said yes, this paper says yes. It's a retrospective study in which 8% of patients had duodenal stents placed, and they showed that that was a significant risk factor for stent dysfunction. So if you can see very obviously this balloon here, this is your target, and a loop of the mainstay of this is quite different, so dilating of strictures is pretty effective for the majority of patients. These things have only got a role in a select group. And stenting actually can be quite useful, but the problem is the migration. It's interesting how all these studies report on migration, but they don't report on what happened to the patient, whether they actually ended up needing surgery. Certainly the stent can make it all the way to the anus, but what you worry about is it getting...
I've had a few experience with people with Crohn's disease previous surgery, particularly in the outline GI tract, breather stenting into those patients.
I guess I've got a heap of experience with that, but I think it's often identifying the problem early. Once they've got a very dilated stomach, it's very established and it's very fibrotic. I think you have a difficult time, but then by the same token, you've probably got dysmotility by that point, and sticking a loop of small bowel onto the stomach doesn't work so well. So I think it is early identification of patients who are at risk, and then early treatment.
To do, of course, and you'll see the pancreas lies immediately behind the stomach. Note, just talking anatomy 101 again, note that the superior mesenteric artery cuts across the duodenum there, and is the second one beyond the celiac artery here, again splitting up into the major vessels there. Now, looks pretty like that, but actually when you get inside and you paint the nerves yellow, because they are easy to spot, you'll see that they're bloody everywhere. It's a spider's web of sympathetic and parasympathetic nerves, and basically this mess here is what's called a celiac plexus. You think it's a nice little discrete little number, we can knock it off, hey, easy peasy lemon squeezy, but it's not really that discrete. Just to remind you, the parasympathetic system, has the vagus nerves which pop down through the either side of the esophagus and then the stomach, and then splay out over the side of the stomach to relieve your parasympathetic innervation. Your sympathetic innervation, though, comes off from the spine, lower down, clavicle that one of our colleagues has had, but and it's going to wear off while you do something. It's going to wear off. It's not going to permanently destroy the nervous system, but the neurolysis is designed to permanently destroy things, so you can put things in there that are going to be pretty awful. So you're only going to... Yeah, quite. So the whole thing is much better if it's earlier on in the course, partly because the tumours tend to infiltrate through nerves and block your access to the nerves, but also by then the patient's operative and performance status is way down the track, and you're not going to make much of a difference to them. So it's inoperable disease for the neurolysis and early on in the course. Just a little bit of history of how we used to do this thing. Again, sympathetic trunk coming down here. Once you're through the diaphragm, you get the celiac plexus with a few these little things that look like the bodies of the spiders, of celiac ganglia, which we'll come to again because they could be little friends in this case. The splanchnic nerves, the classic, the greater, lesser, and least, if you remember them. This was a way, perhaps Ian remembers, I remember, surgeons used to go in and do a laparoscopic splanchnicectomy, a very effective pain-killing thing, but when you've got an operable pancreatic cancer, do you really want your chest opened to do that? So that's the anatomy. Now, traditionally, this is done by the radiologists, by the patient lying on their stomach, and you stick a needle in, very clever, sticking beside the processes of the spine, and you can either aim at the splanchnic nerves as they're coming in before they form the ganglion and destroy this area, or you can, take a big deep breath, and push the needle even further, just hoping you're passing the aorta and the arteries we'll talk about in a minute, and then try and get the alcohol and destructive processes even deeper. So obviously you've got to have balls of steel to do that, or you can be totally gung-ho and go anteriorly and just let's hope that we miss the liver and we miss the stomach and then get it that way. So you can imagine radiologists ain't keen to do it, but there was quite a lot of experience doing it that way. I won't give you the data on that because we don't do it anymore. But this is the way, and it all seems pretty logical. Here you are remembering the CT slices. If you come down here with your your EUS scope, you'll see it sits right where we want to go, and it just seems so logical to snuggle up and kiss this little area nicely with your EUS machine. So it's all very logical to approach it from an EUS point. Contraindications. Okay, well, if you don't know that they've got an inoperable malignancy, it seems silly to do it. If putting a needle in through things, if they're going to bleed, is not a good idea. And if the patient's going to wriggle, because you'll see in a minute, I'll show you a video, the needle's in there for quite a while, and it's in quite deep, and it's near some big bloody containing. So those of you who want colour, here it is, Marius. So this is the region, if you remember on the anatomical diagram, this is where all the mesh of the celiac plexus lies, and that's where we're going to come in and destroy it. I was going to ask Estella, but I won't embarrass her. This study suggests there's not much of a difference. Perhaps the central is a little bit better, but nobody knows. But the fiendish little Japanese have thought, we can get this, the resolution gets better and better and better with these machines. Why not go for the body of the spider? Why not go for those ganglia, if you can see them, and knock them off right at the top? So they've suggested that this is the area we're going to go for a plexus block, so we're going to go in vaguely in this area and we're going to spray it like crazy. But actually, if you look harder, and Japanese guys, their vision is so good, I don't know, you can see that you actually got a ganglia here, and you inject directly into the ganglia and destroy them. So they did this randomized study of a 30-odd in each group, and it looks reasonably convincing. This is sort of the wrong way around in the sense of post-operative reduction, so more reduction up here, and that's the ganglion neurolysis versus the old-fashioned, and again they're suggesting that perhaps it lasts a little bit longer. As you see, that's about sort of 3 months or so is where it all starts differentiating out. So maybe we should be a bit more accurate. Just before we go and show you how it's actually done, how effective is the block? I've been rather perhaps dismissive of it, and I haven't done a block for a long time. And maybe this is why. Clinical success between 25 and 80%, it's really not greatly effective. Is anybody doing blocks? The patient comes out of their sedation, they're going, and need another shot of fentanyl before they go back to the ward, or a bit of morphine. That's actually a good sign. No pain, no gain. That's how I sell it to them. Rare but important, this is the other, for trainees, that's what you're meant to put on the consent form. Abscesses. Thought that maybe if you're introducing a steroid, which you do in the block situation, that might be more, and maybe you should give antibiotics prophylactically if you introduce steroids. And then this is a bit frightening. Why does it occur? Well, just to remind you, you've got your firing around where all these little arteries fire off to the gut, and important things. Liver necrosis has been described as well. But this is the most frightening. Until 2013, this was not described, and we used to go around saying, hey, don't worry. Don't worry, guys. It's never been described. We're not going to paralyze you. You'll be fine. But unfortunately, it has now been described. This famous artery of Adam Kiefert's, which you all remember from your anatomy, is basically it's one of the. A lot of the arterial anatomy in the upper abdomen is unpredictable, and if you're a surgeon, you have to learn the 12 derivatives of the hepatic artery or something or other. But this is also unpredictable as to where these arteries come off, down the paraspinal arteries come off, and some of them will have a major arteriole called the artery of Adam Kiefert's, which supplies the anterior spinal artery to the spinal column. So if you're unlucky, or put your needle too deep, or the material gets to the spinal artery, you can thrombose that, and unfortunately that's not nice. So we have to consent for that. How do we actually do it? Okay, we'll make sure they don't bleed. The mixture is a mixture of local anaesthetic followed by alcohol. Those of you who drink this sort of stuff will realise it's pretty powerful. Makes a mess of you. CP block we don't really do anymore, but that's a mixture of local anaesthetic and steroid. Make sure the don't get hypotension and before we let them off the room. And in fact, I'll go back a bit. Can I go back? Because of the possible hypertension, we usually load them with some fluid beforehand, maybe a litre of reasonably rapid saline before you do that. So here we go. This is a tumour here. Those who do ERCP, I don't do it anymore, will recognise this is already got a metal stent in place. This is oh look, there's a little green arrow showing you. This is the 4 centimetre or odd tumour. You see there's local regional nodes, so that proviso that we've got the diagnosis right. This is not going to be operated on, so I'm pretty happy with this. Just to show off in a minute, I think we'll show you some secondaries in the liver as well, just to confirm this is not going to be operated on. Oh God, I'm going really slowly. Never mind, there you go, 4 centimetres odd. This is my privation report so that Marius can audit me later on. And then what I'm trying to find is, what is this? See if we can be more convincing. Is there something else? I'm just rolling off to the left side, right side, left side. So, have I seen the ganglion? Is this the ganglion? And what am I going to do about it? So, what I actually do is you destroy your field of view, unfortunately, as well. So you've got to be pretty certain you're in the right place. Okay, so this one is much directed, and you just put it straight in there, easy peasy, lemon squeezy, and just destroy that. Okay. So the principles are you're trying to get the sympathetic chain. It's a messy area. You could spray it around, or you can be trying to be targeted. I've missed out the slide on effectiveness, but maybe at 3 months.
So phase and simple cyst and pseudo to the cyst, and that's reiterated over here. Big cysts. This group adds thickened or enhancing cyst walls. Last that look at resected cysts still show that only 15% of them will actually contain adenocarcinoma, and even an IPMN with high-grade dysplasia and adenocarcinoma together, still there's 42% of cysts which contain a high-grade feature, but that means that there's 58% of cysts which are getting resected that don't have high-risk features, and the patient may have avoided a procedure if they'd been more accurately diagnosed. So the challenges are identifying mucinous and non-mucinous cysts, higher and lower risk. What's a true solid component, what's debris or mucin within a cyst, and what's a solid aspect. And trying to accurately identify lesions with high-grade dysplasia or cancer. So there's a few ways that we may be able to improve this. The first is contrast-enhanced EUS. The first attempts at contrast enhancement were actually with CO2 infused through a catheter in an arterial catheter. Naturally, you needed to use angiography at the same time as your EUS, so it made it a little cumbersome, and thankfully we don't do that anymore. But there's also Doppler-enhanced EUS and contrast harmonic EUS. The contrast is injected at the time of the EUS procedure. They're tiny manufactured bubbles, and they're 2 to 10 micrometers, so they pass through the lung circulation and hopefully don't cause any problems. They backscatter signal, but also they resonate, and so you get a signal related to that. The first of these agents was Levervist, which required quite a lot of power to burst or generate a signal from. So they've developed new agents which are made up of different outside layers and gases, which are easier to burst or to get a signal back from. So you can look at those with Doppler, but there appears to be a problem. I don't do EUS with a contrast enhancement and Doppler. So I don't know, but apparently there's a problem with Doppler EUS and blooming, which means that the vessels appear larger than they are, so it's not a particularly accurate type modality. But use of a contrast agent with standard EUS can actually identify enhancement in things like nodules that have, when the contrast goes through, you get enhancement of nodules. You may get enhancement of the lining of the cyst, so that becomes, you can determine whether or not it might be an epithelial or a pseudocyst. And solid lesions as well that are associated with a cyst may enhance, so that might be helpful too. Dr. Kamata has done a study on this and how it compares with standard EUS. They enrolled 581 patients. There are only 70 who actually fell into the category where they had a solitary pancreatic cyst who actually had surgery that they could compare with. And they noted that compared with standard EUS, the sensitivity was much the same, but the specificity for a nodule in predicting cancer was much higher with contrast-enhanced EUS. So you can exclude the cases where it might be mucin or debris, which forms the nodule, and more accurately define those ones which actually are high-grade dysplasial cancer. Another potential avenue for improving the diagnostic accuracy of EUS is using pancreatic cyst biomarkers. There's a recent review which has looked at the most promising markers, and it's way too much information to go through. But there are some that we can identify: non-mucinous and mucinous cyst types, low risk from high risk cyst types for surgery, and SCAs have a particular associated molecular markers which may, you can diagnose them actually most of the time pretty easily with standard EUS, but you may be able to also look at a marker which helps you with that. And a big multi-centre group has looked at molecular markers and clinical features, and they looked at 130 patients with a range of different cysts, and they saw that a composite molecular or clinical marker was actually helpful in diagnosing the cases that would have definitely required surgery. So when they looked at the 74 lesions that didn't require that didn't require surgery, these markers may have identified 67 of these, so that you could have maybe reassured those patients. You only require a small amount of DNA to do the analysis, 0.25 mils. So that is something that's a new thing which may be helpful. Confocal laser endomicroscopy is a development. You can determine which ones they are. It's compatible with a 19-gauge needle, and the alternative to that is that you can put down a 19-gauge needle is actually a spyglass fibre. So there's one study that's done that's looked at this. The problem with the spyglass fibre is that the focal length is 4 to 7 millimetres. So if you're looking at like a 10 millimetre cyst, you've got to be back off the wall this far, and then you get these great photos of like I think that's Jupiter. I'm not quite sure, but this is mucin and papillary structures apparently. So thick fluid in there makes it very hard to see what's going on. This study looked at doing sequential EUS guided procedures, first with Cellvizio, then using a cystoscopy straight after, using spyglass through the same needle straight after, and then doing an EUS FNA. So they found that naturally that spending all that time and having a good look around resulted in very good sensitivity and specificity. That probably the Cellvizio was better than the cystoscopy, but they did have pancreatitis in 2 of the 30 patients, and they both spent 4 to 5 days in hospital. There's probably you have to manipulate the needle within the cyst to try and look around the wall. So you may not, or even though you may be able to diagnose what type of cyst it is, you may not be able to find a high-risk area, which is the thing you're actually looking for to determine whether or not it's a high-risk cyst. Also, it's quite expensive. 79. This is a nice assessment of the cost of the device. £79,000, but basically 180,000